So let's get into our new lesson here for the day, which is all about different types of anemia. We're going to go over in super detail, which is such a precious lesson for NCLEX. And so these are the types of anemia we're going to go over in great detail, which include probably one of the most common anemia that everyone is familiar is iron deficiency. What we also call as microcytic because the cells are smaller, hypochromic because they're kind of pale because of the lack of iron. Remember, it's the iron which makes the cells RBCs have the normal color. With the deficiency of iron, it become less colored or more pale. And then another classic one, which is pernicious anemia, that's the B12 deficiency one, which is also called a macrocytic, means larger cells, or megaloblastic, pretty much the same, yeah, larger immature cells, that's what it means. And then aplastic, which is the one from bone marrow depression. And what is special about aplastic, yeah, that's from bone marrow depression, means is going to cause drop in not only the RBC, but also can affect all the blood cells. Remember, bone marrow is a source of RBC, WBC, and platelets. So the deficiency of WBC and platelets all can happen. So basically what we call as pancytopenia and its effect we're going to see. Also, we look into several different reasons which can cause hemolytic anemia, which because of the rapid destruction of the RBCs, and the causes could be congenital, like by birth, and they all are pretty much, yeah, they all are actually genetic disorders. Like the one we popularly know, sickle cell anemia, thalassemia. We'll talk about them in great detail going forward as well, and also G6PD deficiency, which we don't talk that often, but these all are counted as congenital genetic disorders. And also, hemolytic anemia can happen as an acute problem from transfusion reactions. The other day we were talking about blood transfusion, right? Mismatching blood, right? A-type person is getting B-type blood and vice versa. That can cause reaction. That's something which can cause hemolysis as well. DIC we have heard several times. So these all could be acute reasons for hemolytic anemia. So let's go through more details about each of these one by one, starting with the iron deficiency as the first one. So again, this image shows the appearance of the RBCs based on the types of anemia. So yeah, while the normal RBCs may have the normal shape and size, and appearance. So here you can see microcytic, the cells could be smaller, and the same as is common with hypochromic, as we heard. They both are typically applicable for iron deficiency. That's where the cells become microcytic and hypochromic. And macrocytic is typical of a B12 deficiency. We can talk more about that going forward. So again, let's start further in details with the microcytic hypochromic, that's the iron deficiency anemia. It is mainly because of lack of intake of iron-rich food. And we collect our daily iron need in average, a healthy adult need 15 to 18 milligrams daily, whereas in pregnancy is double, and it's such a repeatedly asked information. Pregnancy, the need is double, as you can see, from 15 to 18, almost go to 30, which is double. And other reasons for anemia could be inadequate absorption. So think about anything which can cause malabsorption. For example, celiac disease, cystic fibrosis, or other malabsorption problems can be reasons for inadequate absorption. Patients with the GA bleed, definitely, right, with the cirrhosis or peptic ulcer, etc., can have GA bleed. They can have significant anemia. And also speak in women 15 to 45. Yes, remember that's the menstrual age. So excess menstrual bleeding could be a reason behind the high risk of anemia in menstruating women. And also can happen with the partial or complete gastrectomy, because remember, gastrectomy can reduce hydrochloric acid, right? So acid is produced from the stomach. And also remember, iron is absorbed in acidic medium. So when the acidity decreases, iron absorption decreases. Also, in developing countries, from blood-sucking parasites like a leech or mosquitoes could be reasons. And also could be from overconsumption of milk in children. Now we know milk is a complete diet for children. It says it's kind of a high nutritive value, but is not good for milk. Is good for everything, but not for iron. So those who are overly fed on milk can have iron deficiency anemia in children specifically. And also in pregnancy, there is higher risk of anemia. Now, in pregnancy, anemia is normal, natural to an extent, what we call as physiologic anemia. But if they have iron deficiency, that can become actual anemia. So that's explained a little bit more right here on the next page. So again, pregnancy, so the expected hemoglobin. Yeah, as I told you, anemia is expected in pregnancy because of hemodilution and what we call as physiologic anemia. Now, what is hemodilution? Remember, the blood volume increased almost 50%. So, yes, again, an adult has around 5 liter blood. So that 5 can become almost 7. Yes, the 5 can go to almost 7 to 8 liters by end of pregnancy. So you can see blood volume is increasing almost 50%, whereas the blood cells are only increasing around 30%. So you can see the 50 and 30. So that disparity causes hemodilution, and that's what we call as physiologic anemia, which is normal and expected in pregnancy. But if it goes less than 11 in first and third trimester, that is concerning. Or if it goes less than 10.5, in second is considered. So overall, you can say 10 point, if it's going less than 10.5 to 11, it is concerning, as you can generalize. Now, looking into the findings of iron deficiency anemia, we have a long list of findings that are listed here. Many of them would be known, some of them may not be known, and we have a lot of description on each of these items on the subsequent pages as we're going to be seeing. So the first one, which everyone is familiar, is pallor, which is visible on palpebral conjunctiva. Now, remember, when we talk about conjunctiva, we have palpebral, right, inside the eyelids, and bulbar over the eyeball. So you can see over the white of the eye. So we have those two conjunctiva. So we observe a pallor, obviously, on the over the palpebral, as you can see. Over the bulbar, by the way, over the bulbar, that's where we look for jaundice that everyone is familiar, right? So that's where we look for jaundice. When patients have jaundice, that's where we observe jaundice in most cases. And we'll talk more about that going forward into the respective topics. So again, pallor, one of the classic findings, fatigue, weakness, cold sensitivity, dyspnea, dizziness, dyspnea, palpitation, a super repair information that you must, wherever possible, try to know the reason, which is the pathophysiology that applies. So palpitation, how palpitation happen. Now remember, the function of RBC, which has hemoglobin, the primary function of RBC or hemoglobin is to transport oxygen, right? So it is the hemoglobin which is containing the iron. That's what is actually transporting the iron, right? The role of RBC or hemoglobin is to transport oxygen. So when the hemoglobin level goes down, we can understand it's going to affect the oxygenation or oxygen transport. So basically, when somebody is anemic, the oxygen transport to the tissue can get affected. So now when the oxygen transport get affected, the heart has to beat faster. When oxygenation to the tissue is decreased to the peripheral tissue, particularly, heart has to beat faster, so that can cause tachycardia. Again, a very classic finding. With this reason, you must know. And also, it can cause headache. Again, I'm going to get you why the reason for many of these findings here on the next page. Brittle hair and nails, yeah, it can affect the nail health, the hair health. And also the nails can form into what they call as spoon nails or 𝗡𝗖𝗟𝗃. We'll see how it happens. A restless leg syndrome, we're going to see that. And edema in legs. Stomatitis is inflammation of the oral mucosa because iron deficiency can affect the oxygen delivery, cellular metabolism, and epithelial integrity, all can get affected with higher risk of stomatitis. So let's look into more details on the reasons behind many of these findings here. So yeah, the first one, anemia and headache. So how anemia can headache? So as we know, RBCs carry oxygen throughout the body. So in anemia, lack of insufficient RBCs leads to decrease in oxygen supply to the brain. So when oxygen supply to the brain is affected, that can be a reason for headache. Now, we heard about the term 𝗓𝗏𝗂𝗫, and it's explained right here, 𝗓𝗏𝗂𝗫, so which is the spoon nails as we heard. So how does this happen? Yes, again, it's a sign of iron deficiency as well. Refers to abnormally thin nails which have lost their convexity, become flat or even concave shape, as we all can see here. And again, how it occurs, iron deficiency affects the keratin formation and nail matrix growth, as well as epithelial tissue growth. So when the nail matrix and the epithelial tissue formation is affected, that leads to thinning of the nail plate, abnormal nail curvature, that's a spoon nail. Now, we don't probably talk about this much, but again, NCLEX can ask you anything, everything. While we don't hear about this that often, there is something we hear very often in relation to nails, what we call as the clubbing of fingers or the drumstick nails, right? The drumstick appearance of the fingers is something. Yes, clubbing of fingers is something we hear very often in various conditions. So let's see what it means and how it occurs. So as you can see, normal nail bed angle is less than 160 degree, and that can increase to more than 180 degree, and that's where the shape changes into the drumstick appearance. So again, that's what it says here. Enlargement of fingertips and toes with the drumstick appearance. So the normal angle of nail is approximately 160 degree. With the clubbing, it can become more than 180 as we saw. And it's caused by increased capillary formation to improve oxygenation, which is accompanied by soft tissue fibrosis. Again, when someone has the chronic hypoxia, so that's where it happens. Basically, the oxygenation to the peripheral tissue can be affected. So when it occurs, so as a compensation, there's increased capillary formation. Is a compensating mechanism. Along with that, there will be soft tissue fibrosis. That's where the fingertips enlarge with the drumstick appears. And again, this is seen in chronic hypoxic conditions such as COPD patients or with a cyanotic heart defects like a 𝗡𝗖𝗟𝗃 So let's look into more findings with this reason with the iron deficiency anemia. The next one we heard, restless leg syndrome, which simply means an irresistible urge to move the legs. How does it happen? If you haven't heard, it is something which happened because of dopamine deficiency. So it's almost similar to Parkinson's. Parkinson's and RLS are caused by deficiency of dopamine, and that's why they both have the common treatment, which is the levodopa kind of drugs. And that's what is explained here. But how does it happen with iron deficiency? So again, it's an irresistible urge to keep the legs moving. Condition most likely caused by deficiency of dopamine. And how does that happen? When iron level is low, the brain does not have enough iron to produce dopamine. So basically, dopamine production needs iron as well. So deficiency of iron can affect the dopamine production, a neurotransmitter that plays a role in regulating the body movement. So that's where they get the restless legs syndrome. And treatment is with the correction of the deficient dopamine, which is with the levodopa, ropinirole. Those kind of drugs are used. Again, we'll talk more about this when we go into our Parkinson's syndrome under neurosensory disorders. Now, how come anemia can lead to edema in legs? And here is the reason. So severe anemia can lead to compensatory tachycardia. Now, we already heard that before, right? When there is lack of oxygen transport because of the reduced hemoglobin, the body is unable to transport oxygen throughout the body. Now, what is the compensation? The heart has to beat faster, right? That's what results in tachycardia. When it's happening for prolonged time, that can result in high output heart failure. So that's what it says here. So severe anemia can lead to compensatory tachycardia and increased cardiac output. And on long term, it can lead to high output heart failure. This can contribute to edema in the legs. Looking into the long list of the diagnostic tests for iron deficiency, what we call as the anemia panel, is a very classic. You don't have to, it's a long list of diagnostic tests, the whole page you can see. You don't have to memorize and explain them, but you should identify these are tests that are involved in the diagnosis of anemia, which include the most popular one we all know, decreasing hemoglobin, hematocrit, 𝗓𝗟 test, the stool for 𝗓𝗚𝗏, which has to identify hidden bleeding in stool. Please go into gastro. You'll find super details about this test. Please search under gastro PowerPoints. You'll find all about 𝗓𝗟 test. And decrease in serum iron. Now, normal iron is 50 to 150 micrograms per dl. Decrease serum ferritin. Now, ferritin is a storage form of iron and normally is 20 to 200. If it's deficient, again, blood cell formation cannot happen. The RBC formation cannot happen. And hemosiderin absent from bone marrow. Hemosiderin is an insoluble iron. It's a form of iron storage in the bone marrow that will be absent. And then TIBC, total iron binding capacity, used to measure the blood's capacity to bind iron with the transferrin. Now, transferrin is that protein which transport iron through the bloodstream. Yes, again, to transport iron through the blood, we needed transferrin. So that is also could be deficient. And then decrease in reticulocyte count. Yes, again, we heard this information several times. When hemoglobin is low with the iron deficiency, yeah, so it can, the reticulocyte count can decrease. Now, normal reticulocyte, remember, is 1 to 2% of all RBCs are reticulocytes, right? Reticulocytes are the immature RBCs. And with the iron deficiency, it decreases. And also with the aplastic anemia, so that's a bone marrow depression. In these two conditions, it can decrease. Whereas with the hemolysis, right, with the rapid RBC breakdown, such as in sickle cell thalassemia, it can increase. Again, it's a long list. It's not for you to memorize, but you should understand there is such a series of tests they do for the diagnosis of anemia. Looking into management. So management is based on the hemoglobin level, as we definitely know. If it's minor, then they try to correct with the dietary supplements. If it's more significant, oral iron preparation. And if it's more significant, they may go for IM or IV, where IV is more preferred. We'll see how and why, step by step. So let's look at the first one, the dietary supplements, which include dark green leafy vegetables. Think about, yeah, the common green leafy vegetables we come across, kale, spinach, broccoli, etc. Dried fruit, whole grain cereals, red meat, liver, egg yolk, etc. They all are the rich source of dietary supplements. Now, talking about oral iron administration, now I would say every single wordings about this information are questions as we have came across. And anytime you see something marked in red as a title, they all are so classic in the test for information. Every single of these wordings are questions. That's what I'm trying to tell you. So with the oral iron, yes, the facts we need to know. So the common products include ferrous gluconate, ferrous sulfate, with these various brand names, and it's administered in empty stomach with the vitamin C. Now, vitamin C is ascorbic acid. Remember, iron is better absorbed in an acidic medium. That's why. So something which provides an acidic source is ideal. Vitamin C or orange juice, which has vitamin C. Liquid iron administered via straw, because it can cause staining of the teeth. Can be diluted with the orange juice, water, etc. Separate by 2 hours from antacids or calcium supplements. Its absorption can get affected. Side effects or iron can cause constipation, dark tarry stool, very classic. Now, usually we talk about dark tarry stool when we talk about patients who are bleeding, upper GA bleed, right, with the gastric bleed, or so esophageal bleed, etc. are the one we often talk about. The dark tarry stool, what we call as melena, what we see with the cirrhosis patient or with the peptic ulcer patients. But also, this also can, presence of patients taking iron also can present with a similar dark tarry stool. But the difference would be if it is dark tarry, the melena in cirrhosis, that will be foul smelling, but here it is not foul smelling. And then IM used when there is intolerance of oral iron. And as I mentioned, IV is preferred over IM. So let's go a bit more here to the next pages. Yes, again, those are the common popular iron resources, as you can see, spinach, tomato, kale, green peas, Brussels sprouts, sweet pepper, broccoli, all those, pretty much most of those green leaf vegetables or similar items are. And as we heard, oral iron, yes, we can give with the orange juice, which is a source of vitamin C, which is acidic, and never with the milk, never ever, because milk is alkaline. Now, looking further into the iron deficiency management, so next we have IM iron. So as we heard, IV is preferred over IM. We'll see why. And the common preparations, iron dextran, which is Imferon, dexferrum. Use one needle to withdraw. Again, every single facts are questions. One needle to withdraw and second to inject, because if not, it can cause staining of the tissue, the skin. And use Z-Track, million times information to prevent tissue staining. We'll see what it is in the next page. Do not aspirate, do not massage. These all can cause more staining, and it can cause complications or adverse reactions. It could be, first of all, it's painful. It can cause sterile abscess, lymphadenitis, anaphylaxis, urticaria, itching, rash, all those can happen as well. So let's talk a bit more about the classic Z-Track here. So what exactly is Z-Track injection? Okay, this image clearly shows what is Z-Track. So you can see the tissue is pulled to one side, as you can see. So yeah, that's a Z-Track. So first we pull the tissue, the skin to one side. So that's what it says here. The Z-Track injection technique seals drug deep inside the muscle, thereby minimizing skin irritation and staining. And it requires a longer needle, 1 inch or longer. So again, as you can see, first we pull the tissue to one side, we insert the needle, and the medicine is placed there. Then we pull the needle out, and you can see once we pull the needle out, and once we release the tissue, the drug is trapped inside. You can see the way the path is kind of broken or obliterated. So the drug that is went inside will not come out to cause a staining. So that's what the Z-Track is. And let's explain even further here on this page. So what we do, first pull the skin by 2.5 to 3.75 centimeter to displace underlying tissue, as we already heard. And while holding the skin in that position, administer the medicine. As you can see, yeah, we inject the medicine there. And the medicine is inside. And then we withdraw the needle. It does not say that, but the next step is we withdraw the needle. And then we release the skin. We withdraw the needle and then we release the skin, allow the skin to retain. And that's going to trap the medicine inside. Again, it's going to trap the medicine inside so that it will not come out. You can see the path is obliterated or broken. So the drug is not going to come out to cause staining outside. So that's what how it helps for the Z-Track. And again, such a repeatedly asked item reported by many people from the real exam as well. And it is applicable for many other drugs as well. Other than iron, and that's what these are. So these are the recommendation for Z-Track. It could be many more, but these are the classic ones we encounter, which include iron we already heard to prevent staining. Ketorolac, is an NSAID, reduce burning and discomfort to the subcu and skin tissue. Haloperidol, yes, we know that's antipsychotic, to prevent leak and irritation to the subcu and skin tissue. And hydroxyzine is an antihistamine, so they also reduce the pain and irritation on the skin, the tissue. Now, as we heard, IV is preferred over IM. It's more effective, less painful, and better tolerated. And the products we use are iron sucrose, venofer, ferrous gluconate, etc. Indications: moderate to severe anemia, typical in pregnant women, chronic kidney disease. We'll talk a lot about kidney disease and anemia going to the respective topics. And this also can cause adverse reactions such as allergy, anaphylaxis, etc. Now we are ready to go into the next type of anemia here, which is pernicious or the macrocytic or the megaloblastic anemia. So let's go to the details on that here, which is again a very precious topic. And that's what we have right here. Yeah, so that's pernicious or the beta deficiency. or the macrocytic or megaloblastic called by different terms. Yeah, again, pernicious or the B12 deficiency, or the macrocytic, which are larger cells, or megaloblastic cells. And the number one reason, yes, again, is lack of the B12 deficiency, how it happened. Now, how B12 deficiency happened, we're going to see going forward on the next pages. Yes, again, those cells are immature and larger, what we call as megaloblastic cells. Looking into the causes of pernicious anemia, the reasons, one of the most commonly seen reasons in questions would be deficiency of intrinsic factor, which is produced by the parietal cells of the stomach and is required for absorption of B12 in intestine. And it's usually accompanied by associated with the hypochlorhydria. Now again, so let me show you this image right here. So if you look into this image right here, I will look here and we'll proceed. So this intrinsic factor, yeah, is a glycoprotein produced by the parietal cells of the stomach, and those are cells here within the antrum. And yeah, you can see that's the antrum. So that's the area which has a parietal cells. And these are the cells which produce hydrochloric acid and intrinsic factor. So this is the cell. These are cells which produce intrinsic factor. So that factor, IF, is required for absorption of B12 in the intestine. For B12 to be absorbed in the intestine, we need to have this intrinsic factor. So again, it's necessary for absorption of B12 in the ileum of the small intestine. Now imagine a patient undergoing gastrectomy, probably very often for peptic ulcer management. They may remove the part of the stomach, particularly the antrum. Again, that's the area which produces acid. So to reduce acidity, they remove the portion, or sometimes for treatment of cancer condition as well, they may remove, or either way, it can result in deficiency of intrinsic factor. And without IF, as we heard, B12 cannot be absorbed in the intestine. That's why all patients who undergo gastrectomy, particularly that area of the stomach, will have lifelong B12 deficiency, and they will need a lifelong monthly B12 injections. And the details we're going to be seeing going forward. So let me take you back. Yes, again. So as we heard, so the deficiency of IF, which is produced by the parietal cells of the stomach, is one of the main reasons. IF is required for absorption of B12, as we heard, usually associated with the hypochlorhydria, which is low HCl. Causes could be from atrophic gastric mucosa, which may be hereditary or autoimmune, but it could be more often, as I already told you, with a gastrectomy. Again, patients undergo gastrectomy, automatically that part of the stomach is removed, and they can result in that condition. Now, don't think always B12 deficiency is happening because of gastrectomy. It also can happen in people who don't have those kind of problem. If you don't consume adequate B12 containing food, that also could be a reason. Yeah, also caused by dietary deficiency of B12, which is common in vegans. That's very classic as well. Now, vegans are people who don't consume no animal source food. The moment you talk about them, you can think about B12 deficiency, and they are just lacking the intake. They have IF, but they're not taking the B12 containing food. So for them, we can correct that even with the food that are rich in B12, like a soybean is a non-animal source, one of the number one source for vegans. And also oral supplements can be given. They don't need the monthly injection, like those who undergone gastrectomy. And I'm going to get you into that more details here. Now, looking into the function of B12. Now, when we talk about B12 deficiency, definitely we're talking here about B12 deficiency anemia. That is one of the main involvement of B12 deficiency, but don't think that is the only function of B12. It also has other significant functions we're going to be talking right here. So it has three classic functions. It has a role in RBC maturation. That's what we're talking right here. It also has a role in maturation of the GI tract cells. Also has a role in maintenance function of the CNS and PNS. So likewise, it can affect functioning of several different systems. As you can see, the first one, again, maturation of RBC deficiency leads to anemia, as we already discussed, can cause pallor, weakness, palpitation, dyspnea. And second is GI tract cells maturation. Deficiency leads to sore mouth and the very classic beefy red tongue, you will see that a lot in question. Weight loss, dyspepsia, which is indigestion, constipation, diarrhea, etc. And also needed for maintenance function of CNS and PNS. So deficiency can lead to CNS and PNS symptoms. And we'll see more details on that. Yeah, these are the CNS and PNS symptoms patient can present. They can present with the peripheral neuropathy, like a tingling, numbness, etc. Neuromuscular impairment can cause gait issues, poor balance, paralysis, etc. Memory loss, dementia, depression, psychosis, and severe or prolonged deficiency can cause all these symptoms as well. Again, it can cause neurological symptoms along with the other symptoms as we are talking here. So yeah, that's a classic beefy red tongue we heard, which is very classic for pernicious anemia. So yeah, they have also involvement of the oral mucosa, which can affect their the ingestion of food. So they won't be able to tolerate a spicy kind of food. So you have to be managing their diet accordingly with the beefy red tongue and the oral mucosal health issues. Now, when we talk about beefy red tongue, also compare with the strawberry tongue. We always talk when we talk about Kawasaki disease and scarlet. We will talk about them in the respective topics going forward. Yes, again, very classic topics will come across. Now, looking into the diagnosis, we have a long list of diagnostic tests that are listed here, so which include gastric analysis that can exhibit decrease in free HCl. Remember, we were talking about the hypochlorhydria. The acidity level can be low. Blood smear shows oval macrocytic larger cells with a proportional hemoglobin. Bone marrow studies shows increased megaloblasts, again abnormally large immature cells, and large amount of reticulocytes in blood following parental beetle. So once they get the beetle, now RBCs can be produced normally. So then there can be an increase in the reticulocyte count. And the very classic, a bit complex diagnostic test, which is very often seen in the test, that is Schilling test. So it measures absorption of radioactive beetle both before and after parental administration of IF. And that's what is explained right here in this image, as you can see. So again, it's a bit complex test. It's a very classic test, as I mentioned. So we're going to see on the next page what exactly this test is. You don't have to explain that to pass NCLEX, but you should understand the purposes. And that's exactly what we have right here. It measures absorption of beetle both before and after administration of IF. So as we already heard, right? We already heard that. So for absorption of beetle in the intestine, we need an intrinsic factor from the stomach. Without the IF from the stomach, beetle cannot be absorbed in the intestine. So we're looking to see how much beetle can be absorbed when there is IF and when there is no IF. It's a comparison, how much IF can be absorbed when there is IF and when there is no IF. And how do we do it? So how do we do it? So that's what this image shows right here briefly. So you can see patient will be getting radioactive beetle orally. So this is the first phase. In the first phase, they get radioactive beetle orally. And also, along with that, they'll be getting regular beetle parenterally. Yeah, they get regular beetle parenterally. And patient's urine will be collected for 24 to 48 hours. So how does it work? Let me get you a preview on that. Again, as I told you, so what we do here in this test is we are looking to see how much beetle can be absorbed when there is IF, when there is no IF. So in the first phase of the test is a, and again, it's a two-phase test. In the first phase, what they do, they give oral radioactive beetle, and along with that, they give injectable regular beetle. The purpose of this regular beetle is we don't want this radioactive beetle to get absorbed and stay in the body, which is harmful to the body. So we just want that radioactive beetle, which is given orally, to go through the intestine, get absorbed, and get excreted. When there is regular beetle throughout the body that is saturating the tissue, that should not be an issue. That's why they're getting regular beetle along with radioactive beetle. So again, patients given oral radioactive beetle. So just like we take any other medicine, it goes through GI tract, but for this beetle to get absorbed, for the radioactive beetle to get absorbed, we need to have intrinsic factor, as we already know. So if you have IF, so out of whatever we give, at least 10% of what we give will be absorbed into the body. If it's absorbed in the next 24, 40 hours, that'll be getting out through the urine. So we're collecting the urine to see how much is coming out. So how much is coming out is proportionate to how much was absorbed. So that is the first phase of the test. If it's less than 10%, that indicates there is deficiency of intrinsic factor. So that's the first phase of the test. Now, in the second phase test, what they do is pretty similar. It's pretty similar. All the steps are done. They get the oral radioactive 𝗡𝗖𝗟. They get the injectable non-radioactive 𝗡𝗖𝗟, but they'll be also getting another injection of intrinsic. They'll be getting also intrinsic factor here. So in the first phase, again, there was no intrinsic factor. Now there is intrinsic factor when we give parenterally. Now we do the same test. So now that there is IF, as this radioactive 𝗡𝗖𝗟 is going down, it'll be able to be absorbed better into the body and it's able to be coming out to the urine. So we are comparing how much 𝗡𝗖𝗟 can be absorbed when there is no IF and when there is IF. So it is that comparison right here. Once more, again, I'm going to get you further details on the next page to make it fully clear. Once more, Schilling test. It measures absorption of radioactive 𝗡𝗖𝗟 both before and after parenteral administration of IF. So let's look into the full details right here on next page. What we already heard is what we're going to be seeing here once more to make it further clear. So as you can see, it is a multi-step procedure which is performed over 2 or more weeks. Fasting client is given radioactive 𝗡𝗖𝗟 by mouth, accompanied by non-radioactive 𝗡𝗖𝗟 IM, which prevent the radioactive 𝗡𝗖𝗟 getting absorbed in the tissue. And then measurement done with 24-48 hours urine specimen, which shows the amount of 𝗡𝗖𝗟 absorbed through the GI tract. As we already heard, normal absorption is at least 10%. At least 10% of what we give, it should be absorbed. And if absorption less than 10, that indicates pernicious anemia. So this is the first phase of the test. This much is the first phase. And the second phase, the test is performed a week later after giving parenteral IF. So again, here, they also give parenteral IF, as we already heard, along with the radioactive 𝗡𝗖𝗟 orally and regular 𝗡𝗖𝗟 parenterally. And then again, the same process, we collect the 24-48 hours urine. So we are comparing how much 𝗡𝗖𝗟 is absorbed in the first phase without the IF. Now that there is IF, how much is absorbed. So we are comparing with and without and with how much with and without how much 𝗡𝗖𝗟 is absorbed. That's what we're looking for in this test. Yeah, again, it's a bit complex test. You don't have to explain this whole process to pass NCLEX, but you should have an understanding, as I already told you. Now, looking into management of pernicious anemia, they get monthly 𝗡𝗖𝗟 injection, as we heard. Yes, if they have the IF deficiency, again, there's a case of patients with a gastrectomy. They're lacking the IF. They are the one who need a lifelong monthly 𝗡𝗖𝗟 injection, iron and folic acid supplements, blood transfusion in severe case, dietary supplements of 𝗡𝗖𝗟, which is ideal for vegans. Again, vegans, if they're not taking the 𝗡𝗖𝗟-rich food, they don't have to go for ingestion. That's not necessarily. They can take oral supplements, which are available. Yes, again, the animal source food. These are the ideal source: meat, milk products, fish, etc. And major plant source is soybean. So that would be a good source for vegans probably. And also, again, these supplements are available in oral form, just like other vitamin tablets. These are also available as tablets as well. That could be also a good option for vegans or those who have the lack of intake. And yes, again, when we talk about vegetarians, remember, there are different types of vegetarians, right? Lacto, ovo, and then vegans, right? Lacto are the one who take milk plus their regular vegetarian food. Ovo, they take egg. Lacto, ovo, they take both. But when we say vegans, understand they don't take no animal source, not even egg, not even milk. So the other one who are likely to have this significant 𝗡𝗖𝗟 deficiency, again, as we heard, 𝗡𝗖𝗟 sources equal animal source food. Such a repeatedly asked information. Looking into the nursing management of pernicious anemia, balanced diet, high in protein, iron, vitamins. If mouth sores, avoid highly spicy and very hot food. Provide mouth care before and after meal with a soft toothbrush and non-irritating rinse. Bed rest for severe anemia. Instead, the need for lifelong beta therapy, as we already heard. Again, for those who have undergone gastrectomy and those who have the lack of IF are the one who need it essentially. Now we are getting into the third type of anemia, which is aplastic, and that is from bone marrow depression. And let's look into the details on that right here. So bone marrow depression leads to pancytopenia. As we already know, it can cause drop in the RBC, WBC, and platelets. So patients can not only have symptoms of anemia, they can have risk of bleeding, they can have risk of infection, etc. there. Causes autoimmune, or it could be idiosyncratic reactions, which are abnormal drug reaction, like unique for a particular person. These are kind of adverse reactions, like which we cannot predict sometime. Think about Stevens-Johnson syndrome, right? That's one of the examples of idiosyncratic reaction. So here, like with these drugs also, like benzene, chloramphenicol, or chemo drugs, these drugs can often or sometimes cause this unpredictable bone marrow depression, and that's what we call as an idiosyncratic reaction. That could be one of the main reason for this condition to happen, or sometimes it could be autoimmune, unknown reasons, or maybe from radiation as well. So there are several different reasons which can cause this condition. And as we know, again, our bone marrow, we have the red bone marrow, that's a functional marrow. And so the yellow marrow, that's a marrow that has lost the hematopoietic function. So basically in bone marrow depression, aplastic anemia, so the patient's red bone marrow can convert into yellow marrow. So there is no functional marrow to produce the blood cells. So that's kind of how it happens. And looking into the findings, diagnosis, as we already heard, they can present with not only anemia, they can have risk of infection and risk of bleeding. So we have to consider all three complications and its management. Diagnosis by bone marrow biopsy, which shows fatty replacement of the bone marrow. Yes, again, the red bone marrow kind of changed into fatty marrow, the yellow marrow, which is the fatty replacement. So this is a briefing of what we just heard there. So again, the pathogenesis, the multipotent hematopoietic stem cells are destroyed by the cytotoxic T cells or direct cytotoxic injury, which leads to life-threatening bone marrow failure. You don't have to explain, but just understand it's a bone marrow failure, which caused the bone marrow depression and the pancytopenia. They can present with we already heard the pancytopenia, the anemia, with the fatigue, weakness, pallor, leukopenia with the recurrent infection, thrombocytopenia with the bleeding, bruising. Common causes, kind of you already heard, autoimmune, medications like chemo, immunosuppressants, idiosyncratic reactions, we already heard that, ionizing radiations and toxins, even viral infections like HIV, viral hepatitis, all can cause it sometimes as well. And diagnosis by bone marrow aspiration and biopsy. And looking into the management is with the blood transfusion. Yeah, if they're severely anemic, they might need transfusion. We already have gone through full details about the transfusion. Bone marrow stem cell transplant. We'll talk a lot about that when we go to oncology in the coming days. Chemo immunosuppressive therapy with a combination of different drugs such as cyclophosphamide, cyclosporin, anti-thymocyte globulin is a drug which particularly suppresses the T cells. Remember, this is the primary responsibility of the immunity is through the T cells or the cellular immunity. So it's going to drugs that can suppress the immunity and can reduce the destruction of the blood forming cells. That's how it works. Also, patients will need colony stimulating factors for increasing the count. We already know what are the colony stimulating factors, which are the drugs to increase the the WBC, RBC, and platelet respectively. As we increase the WBC, the drugs we use are filgrastim and pegfilgrastim. To increase RBC, we give erythropoietin alpha, darbepoetin alpha, etc. And to increase platelet count, we provide oprelvecin and plate. Yeah, again, those are for platelet increase. So those medications may be necessary for these patients as well. And looking into the nursing aspects, minimize risk of infection. Again, you already heard the three problems they can have. They have low RBC, so basically have anemia. Low WBC means high risk of infection, and low platelets means risk of bleeding. So they have these three problems. So interventions are focused on preventing or managing these three categories of problems. So first is minimize risk of infection with the neutropenic precautions, mouth care after meals, care for patients with anemia, with high protein, high vitamin diet, adequate rest, minimize risk of bleeding with avoid IM injections, hematous urine and stool. Yeah, so checking for the stool for occult blood, the actors we talked. Soft toothbrush, not dental floss, and a very classic information, use electric razor. Yes, for someone with a risk of bleeding, always use electric razor, not safety razor. That's a trap. Remember, safety razor is not safe for NCLEX. We need to use electric razor. Such a repeatedly asked question. They always ask that when patients are on anticoagulants like heparin, warfarin, etc. They ask the same information because there is added risk of bleeding. Now we have the very last type of anemia here, which is hemolytic anemia, which is again a complex category of anemia because it can be caused by several different reasons, which we're going to see right here. So it's a long list of reasons. Yeah, again, it's anemia due to increased rate of RBC destruction. It's kind of rapid RBC destruction. That's what causes hemolytic anemia. The cause is categorized into congenital and acute. Congenital include G6PD deficiency. We're going to see that soon. Hereditary spherocytosis. We'll talk about super details about sickle cell and thalassemia on the way. Every single word about sickle cell is a question as I have encountered. So was thalassemia. So these all are genetic disorders. Yeah, they all are genetic issues. And then also acute reasons like a transfusion reaction. Yeah, so we already heard mismatching blood, right? ABO incompatibility, RH incompatibility, all those can cause transfusion reactions. DIC, these all could be acute reasons. So let's look further into more details on this. So a little bit about G6PD deficiency. So G6PD is an enzyme we all have. We all have this enzyme called the G6PD. That's an enzyme which protects our RBCs from hemolyzing, breaking down. So those who don't have that enzyme, when they take certain food or drugs, the RBC can easily break down. And those drugs and food, what we call as chemical oxidants. Those oxidants can break down the blood cell. And that's what it says here. Again, it's a sex-linked or X-linked disorder, just like hemophilia A and B. This is also sex-linked. It's a red cell enzyme which protects the RBCs from hemolysis. And its deficiency makes RBCs more susceptible to hemolysis after ingestion of certain food and drugs, what we call as chemical oxidants. And here is a list of those chemical oxidants right here. You can see these are the drugs which include aspirin, quinine, sulfonamides, chloramphenicol, thiazide diuretics, maybe many more, but these are the classic ones you may see. And foods such as soybean, fava bean, etc. These all are drugs again which can break down the RBCs easily, resulting in hemolysis and anemia. Now, that's a hereditary spherocytosis. It's an autosomal dominant disorder characterized by sphere-shaped RBCs. Now, we can see the normal RBCs have the biconcave shape, and here it has a spherical shape. You can see the spherocytosis. But these RBCs are at a high rate of hemolysis. They can easily break down. So again, it's a genetic disorder. And once more, the other two will talk on the way. Yeah, the sickle cell and thalassemia will talk a lot of details on the way going forward. And yeah, so the acute reasons include transfusion reactions, DIC. So DIC, we heard that several times, right? The disseminated intravascular coagulation, or we also call it consumptive coagulopathy. So it's abnormal clotting, which consumes all the clotting factors, followed by heavy bleeding. So that's what is DIC. Yes, again, due to this one or other reason, body start to utilize all the clotting factors. We heard we have several clotting. For clotting, we need platelets, we need fibrinogen, we need a lot of clotting factors, right? There are 12 clotting factors. etc. So with the DIC, it can consume all those clotting factors, and we can be left with the no clotting factors, and that's what we call as consumption. It's going to consume all the clotting factors. That's what it says. Abnormal clotting, which consumes all the clotting factors, followed by heavy bleeding. Now, looking into the long list of symptoms of hemolytic anemia, and the symptoms depend on the cause, degree of anemia, and nature of the disease. And again, for any anemia, the first thing we know is pallor, can cause chills, fever, irritability, nausea, vomiting, diarrhea, melena, hematuria, dyspnea, and a few classic ones to emphasize can cause jaundice, can cause splenomegaly, hepatomegaly. We'll see why and how. Can cause gallstones, cholelithiasis. So let's talk about them specifically, why it can cause these symptoms. So jaundice with hemolytic anemia. So why jaundice can occur with the hemolysis? So basically, destruction of RBCs with the release of unconjugated bilirubin more than what the liver can conjugate. So this image clearly explains how. So understand when RBC breakdown, right? RBCs contain hemoglobin. When the hemoglobin breakdown, you remember hemoglobin has heme, the iron, globin, the protein. And when this heme breaks down, it's going to release biliverdin as the first pigment. And then it's going to convert into unconjugated bilirubin and into conjugated. Yes, again, the breakdown of the iron containing part of the hemoglobin, the heme. So that's where it leads into the release of the bile pigments. So when RBC is breaking down, it's going to release the first biliverdin, then into unconjugated. Now unconjugated is same as indirect or fat soluble. And a healthy liver will convert that into conjugated or direct or the water soluble. But if the breakdown is too fast, it's beyond the capacity of the liver to convert or conjugate. So that's where this can cause the unconjugated, the fat soluble, to go high. So again, with the rapid breakdown, the buildup of unconjugated is beyond the capacity of the liver to conjugate. So that's where it can cause increase in bilirubin, resulting in jaundice, as we are talking. Now, we talk about this information in several different places. This is such a precious information we talk. Like when we go into the jaundice in newborn, we talk the same. Yes, remember, all babies inside the uterus, the fetal life, they have extra RBCs, right? They have the fetal polycythemia. After birth, they don't need that many RBCs. A lot of them break down, but the breakdown is too rapid. So that's where they get the physiologic jaundice, which is very common in newborn babies. But if they have other complications that can cause even more breakdown, that can cause pathologic jaundice. Again, we'll see a lot of details on that. And every single word about those kind of topics are questions that we will encounter on the way. When we go into maternity, newborn, we'll talk about them. So again, as we heard, so rapid RBC breakdown can cause jaundice. Now, also how the workload, how there is splenomegaly. Yeah, we heard there is splenomegaly, hepatomegaly with the hemolysis. Now remember, liver and spleen, these are seriously involved in the RBC breakdown and the clearance of those breakdown products from the blood. So they are called, so spleen is particularly called the graveyard of RBCs. Basically, the workload of those organs increase, resulting in those organs to enlarge. And that's why we're talking here. So yes, with the rapid hemolysis, the workload of liver and spleen increase. Again, spleen is the graveyard of RBCs. And we'll talk about this very specifically when we go into sickle cell anemia, particularly, or also as thalassemia with sickle cell in particularly. There's rapid hemolysis. Remember, our normal RBC's lifespan is 110 to 120 days. With sickle cell, their lifespan is just 6 to 20 days. They break down so fast, so the workload of spleen can increase. So that can cause the waste products to lodge into the spleen. That can tap a lot of blood there. That can cause what we call splenic crisis or splenic sequestration. And that is the reason patients with the sickle cell anemia may have to undergo splenectomy as one of the life-saving intervention, which is not something desirable, but something that may be needed to save their life. We'll talk about that in more detail on the way. And why gallstones can happen with hemolysis. Now, when we talk about gallstones, you might remember gallstones are typically formed of high cholesterol, as we understand, but also it can be formed of bile pigments. When there's rapid, yes, so this you can see the gallstones can be formed of cholesterol, the one we know popularly, but also can be from bile pigments. So again, rapid hemolysis increases bile pigment, which can form into stone. That's why the risk is very high with the sickle cell anemia, thalassemia, etc. Now, looking into the diagnosis and management of hemolytic anemia. So diagnosis, yeah, here also we look into the, we'll find that because in hemoglobin hematocrit. And also very classically, we already heard the reticulocyte count can get affected. So here, the reticulocyte count can increase. Now remember, the normal is 1 to 2%, and we already heard with the iron deficiency and aplastic that can decrease. But with the hemolytic means when there's rapid destruction, there's overproduction. When there's rapid destruction, there's overproduction, and that's why it can cause increase in the reticulocyte count we're talking. And again, when you go into sickle cell and all, we'll talk a lot about that. This is the reason they also can have this bone marrow crisis. They have bone pain, etc., because the activity of the bone marrow can increase because you need to produce more RBCs there. And also increase in ongoing conjugated bilirubin. We already heard that. Yeah, again, rapid destruction beyond the capacity. So bile pigments start to build up. And management depend on the cause, blood transfusion. Corticosteroids may help to suppress immune destruction of RBCs. Now, if the cause is particularly autoimmune, this can help to suppress the immune response, which leads into the RBC destruction. Folic acid supplements, and sometimes they might need a splenectomy. And we have some details about splenectomy we're going to be talking here. So this will be the last topic we'll be covering in this lesson, splenectomy. So let's talk about splenectomy. So common indications: a rupture of spleen due to trauma, accidental tearing during surgery, etc. Splenomegaly due to various diseases such as infectious mononucleosis, a very classic topic. We'll see that to the end of this lesson. Sickle cell, I already told you, these are the very classic indications of splenectomy. Not indicated in children unless it's unavoidable. And we have heard this information several times before, because the other organs in RES, right, there's a reticuloendothelial system, the immune system, are not functional yet in children. Their primary source of immunity is from spleen. That's why we try to avoid splenectomy in young children. And again, this is the RES. We already heard a reticuloendothelial system, what we also currently call as the MPS, that's a mononuclear phagocyte system. Again, it's a fundamental part of the natural immune system we have, and that includes these different organs such as spleen, the Kupffer cells of liver, lymph nodes, bone marrow. These all are part of the RES or the MPS. Looking into the nursing aspects with the splenectomy, very classic information, and I would say most of these facts are straight questions. So pre-op care, administer pneumococcal vaccine. Now, I'll start from there as the first thing. Now, pneumococcal, now when we talk about vaccines, everyone knows flu vaccine is a vaccine that can be given for everyone above 6 months. Annually, flu vaccine can be given for everyone, whereas pneumococcal vaccine is a vaccine limited to young children and elderly. Before it was 65, now it is above 50. But again, it's for people above 50 or young children. That's the other one who need to get the pneumococcal vaccine. Now, if someone need to get it other than that age, there should be some specific criteria. And one of the number one criteria who needs a PCV vaccine younger than 2 years, the younger one, or above 50, include number one is immunosuppression, including splenectomy. That's exactly what you will see in so many cases, and that's exactly what we're talking right here. So these are the indications of pneumococcal vaccine other than elderly or young children. Again, the number one talking here is splenectomy or anyone immunosuppressed. That's the same thing. And chronic disease conditions like diabetes, hypertension, alcohol, etc., which is not that specific, but NCLEX will always test you on immunodeficiency from this procedure with a very high risk of pneumonia. So let's go back and explain this further here. Again, so when patients undergo this, they need to get pneumococcal vaccine in advance and post-op care. Monitor for hemorrhage and shock. Again, we know spleen is a highly vascular organ, so we store almost 200 ml of blood. So its removal can cause bleeding. It's a vascular organ, more risk of hemorrhage. And monitor for signs of infection. We already heard spleen has a significant role in immunity. So we had to look for signs of infection in these patients, and such as pneumonia or UTI. And the interesting thing, temperature may not be the best indicator. Now let me explain that. So when we get an infection, we understand our body temperature, that fever can increase. And also we also know that fever is not a disease, right? Fever is often a sign of an underlying disease condition, such as an infection in most cases. But when we get that infection or an inflammation, our body temperature increasing, it is body's natural response. We get that fever because we have the normal immunity. So the normal immunity is what helps us to have the rising temperature. Now, if somebody is immunosuppressed, they can have an infection, but they won't have the fever rising as a routine. So we cannot rely on the fever alone in that case. That's what we're talking right here. Temperature may not be the best indicator. Fever without associated infection is common after splenectomy. Very classic information. Now we talk the same. So basically, even low-grade temperature can be something of very concern. And this also applies for a bunch of other conditions like classically encountered, even low-grade. Now we know that when you talk about temperature, we don't usually treat anything less than 100.4 or maybe 1.1, 101. We don't treat anything less than that as considered as fever, or we don't take it seriously. But when it comes into a certain condition, even the low-grade fever can be of extreme significance, and that's what these conditions are. So these are some conditions where even low temperature is a high priority, which include post-splenectomy, post-thyroidectomy. That could be an indication of thyroid storm. Remember, when patients with the hyperthyroidism and all, when they remove the gland, that can cause sudden release of the thyroid hormone into the bloodstream, the T3, T4, that can cause thyroid storm or thyroid toxicosis. So a warning sign, even temperature 99.5, 100 could be a warning sign of that, should be taken seriously. And we already heard immunosuppression, post-transplant patients, neonates, we have very high risk of infection. These all are patients where even the low-grade temperature, again, is of high significance. So yeah, we are talking about the need to monitor for signs of infection. They might need prophylactic antibiotic for the same reason. Encourage patient to report even minor signs of infection. Again, is all focusing on the high risk of infection, as you can see. And observe for abdominal distension and discomfort, secondary to expansion of intestine and stomach. An abdominal binder may be used to reduce the distension. Ambulate early. Encourage incident spirometer to reduce the risk of atelectasis and pneumonia. Now, we heard about the use of abdominal binder. And I want to say something about abdominal binder here. So avoid girdles and abdominal binders for patients with a hiatal hernia. It's a very classic information you have encountered as well, probably. So for patients with the hiatal hernia, avoid abdominal binder. Now, if you remember what is hiatal hernia, we know that is protrusion of the part of the stomach into the thoracic cavity, accompanied by acid reflux and irritation. Just like acid reflux can have all the symptoms, burning, etc., etc. So again, for patients with this condition, hiatal hernia, don't give them a binder that can make the symptoms even worse. And with that being said, this lesson is ending here.